Good morning, everybody. How's everybody doing? Wait, I didn't hear anything. How is everybody doing? Thank you. Thank you. And thank you to NMAPA and everybody else for allowing us to speak on this important topic. The Cancer Moonshot is something that you may or may not know about, but it's an important resource for your patients in oncology for sure. During today's session, we'll provide background on the Cancer Moonshot and its goal to end cancer as we know it. This discussion will allow everybody to understand how foundations and industry have worked together with government to meet the goals of the Moonshot and what more can be done by working together. The panel will provide valuable insights on the types of assistance and resources that advocates and organizations can provide to further assist cancer patients in their healthcare journey. The session objective is to identify deficiencies in providing cancer patients with access to proper care and resources, and what changes could be made to positively address them. Now, there's going to be a lot of questions I'm sure you're going to have during the course of the presentation. For this one in particular, if you guys can just hold those questions to the end, we're going to leave a lot of time for Q&A at the end for sure. So let's also advance. So to start off, we're going to have both of the other panelists also discuss who they are and their organizations. So let me introduce both Carla and Kim. So Carla, go ahead.
Hi, everybody. It is so great to be here. I have not been to this conference before, but Alan assures me I am with my people. So it is great to see you all. I'm the CEO of Family Reach. Family Reach is a national nonprofit organization solely focused on meeting basic needs for cancer patients: housing, food, transportation, and utilities. We have been around for 28 years addressing health equity in cancer because our healthcare system is broken. People get cancer, people with families, people with jobs, people who have monthly bills coming in just like you and me. And when cancer strikes, work is interrupted or stopped, so is the income, but the bills do not stop. The expenses get higher, out-of-pocket costs to access care and adhere to treatment. So Family Reach has a bevy of licensed social workers and navigators that are empowering patients, caregivers, healthcare providers, nonprofit organizations, advocates on how to talk about your finances, how to normalize the conversation, how to wipe out the shame and the fear in talking about finances, how to find resources. There are tens of thousands of basic need resources across the country that nobody knows about. So easy for us to connect, but first you have to talk about it. And then we offer emergency financial assistance in, again, housing, food, transportation, utilities, so that patients can take care of their families and get cancer care. So that is what Family Reach does. We have been part of the Cancer Moonshot since its inception.
And let me also introduce Kim as well. Kim?
Hi, I'm Kim Zabarak, Associate Vice President of Policy with Cancer Care. Cancer Care was founded in 1944, so this year marks our 80th anniversary as an organization, which we're very excited about. So Cancer Care is a leading national organization that provides free professional support services and information to help people manage the practical, emotional, and financial challenges of a cancer diagnosis. I'll go into a little bit more of the details of the types of services we provide. This too is my first time at this conference, and I'm really looking forward to it, and thank you all.
Thanks, Kim. And I'm Alan Klein. I'm Chief Development Officer of HealthWell Foundation. HealthWell Foundation programs out assistance on the funding side for patients who can't afford their out-of-pocket medication copays. Last year, we were fortunate enough to program out over $1 billion in grant awards to patients across over 60 different disease areas, including a lot in oncology, which is why we're so invested in this space. So with that, as the dean and eldest statesman of participation in the Cancer Moonshot, we're going to start with Carla to describe what Family Reach does and a little bit of background on the Moonshot and its origination.
The origination of the moonshot was back in 1969 when they literally said, we want to think really big and put a man on the moon. And that's where the moonshot, it felt impossible. It was daunting, but they said, let's go for it. And then when Obama took over the administration in 2016, he brought back the cancer moonshot, and that was to end cancer as we know it. The goal with the original cancer moonshot was really to accelerate where we thought we would be with cancer research from 10 years to 5 years. And the goal was to break down the silos that researchers across the globe were working in. So really focused on research with a little bit of patient advocacy blended in. He put Vice President Biden in charge of the moonshot because of his deep connection to cancer and his son, Beau, who lost his life to glioblastoma. I am a 2-time cancer survivor. I thank God for the research. It has come so far, and I can say the moonshot is working in terms of research acceleration. When Biden left the White House, he continued the moonshot work with the Biden Cancer Initiative. Same goals in research, but really expanded it to advocacy, multicultural, socioeconomic disparities for cancer patients to bridge that gap between patient care and science. And then when he took over as president, he brought back the cancer moonshot and again continued to really lean into health equity and patient advocacy. And the goal for the current cancer moonshot is to increase cancer survivor rates by 50% in 25 years. This is so doable when you know there's a stat that I live by, and that is 1 out of 3 cancer deaths in this country could be prevented by removing socioeconomic barriers. So we could reach this goal really fast, honestly, if they wanted to. They just need to know, I think, what we all see every day. They need to understand that patient journey and what actually really needs to be done in order to increase survival rates. As part of the Cancer Moonshot, I'm in that space telling them what I see every day, telling them about a single mother of 4 young children who has stage 4 ovarian cancer. The hospital called us, there was a hospital in Boston that called us in December, asking for money for a tent. This woman had her car repossessed and was evicted because she could not work. She's homeless with 4 children in stage 4 cancer in Boston in December, and they want money for a tent. This woman's chance of survival are dramatically lower if we could address her needs. So the Moonshot aims at setting a platform, setting a stage for all of us to come in and collaborate and tell our stories and to understand our niche. We each have specific focuses, but we're not going to solve it alone. So the Moonshot sets this platform to say, come together, talk amongst yourselves, figure out this patient journey and where you're all linked, and we will elevate that and we will help you raise awareness. There are 3 pillars of the Moonshot, and that is collaboration, which I just talked about, work together. You know the patient journey better than anybody else. Innovation, what do we need to do differently? How do we need to think about this problem? And then awareness. We might have this solved, but if nobody knows about it, the patients aren't going to be able to access it. Again, these 3 pillars, critically important for everybody to understand the patient reality, and that's what we all need to be so loud and so proud to share so that we can find the right solutions, the right collaborations, and the right innovations to have a true impact. Some examples of what we've done through the Cancer Moonshot. When we first joined, we were just emergency financial assistance. That was I call that the 911. Getting the call in the office, a patient screaming, the repo guy is in the driveway, he's going to take my car, help me. Give me the number of the tow truck, calling them, giving them a credit card, put the car down, go away. We were emergency financial assistance. Because of the Moonshot and our innovation, we were able to add financial education and guidance and tips to talk about to talk about finances, to normalize the conversation. And we were able to unearth resource navigation, again, connecting patients, healthcare providers, caregivers to the tens of thousands of basic need resources that are out there. So the Moonshot allowed us to expand our reach, our scale, our impact, and partner with nonprofits that were entrenched in under-resourced parts of the country. They had the trust of the patient, they had the audience, they just didn't have the know-how or the resources to help with this financial crisis. So through partnerships and collaborations, we have had a tremendous impact on people that we weren't reaching otherwise through the Moonshot. With HealthWell, we partnered, this current Moonshot administration really focused on clinical trials. Clinical trials are, for some, a last chance at survival, for others, an opportunity to take advantage of the new science and a better chance of surviving in your first round of treatment. The clinical trials are really misunderstood and really underrepresented. Diversity in clinical trials is critically important. I think right now the average Black enrollment in clinical trials is about 8.5%, and in Hispanic, under 10%. We were really focused together to reach everyone and make sure if they were accepted to trials, they could say yes, and they could stay adherent. So together, we were able to, and we're still in it, but we just got the first bit of data around this. We have been able to, and I wrote this down because I didn't want to get it wrong. We have been able to help patients who, and we asked for the income, the average income, there's 33% of the patients that we helped get on and stay on a clinical trial were making under $20,000 a year after a cancer diagnosis. And there was also the other 31% were making under $40,000 a year. So covering their basic needs so that they could put cancer first was critically important to save their life and to advance cancer. Anything I missed in our partnership?
Other than that you guys are fabulous, no.
Thank you.
Thank you for that. And just to give some background on HealthWell, as I mentioned, we're kind of really focused on one area, and that's out-of-pocket medication copays, which of course are unbelievably gating issue for everybody with a cancer diagnosis. The last thing that anybody should have to worry about after getting a cancer diagnosis is how to pay for their meds. Let's get them focused on how to get better, please, not how to afford to get better. This is the United States of America, the richest country on planet Earth. I don't know what we're thinking by not making this a priority. So the fact that the Biden administration and the Obama administration and other administrations are putting this front and center now is very exciting. They're calling for the industry in general, and that's not-for-profits, that's organizations, that's for-profits, that's everybody, to come together under one umbrella with that goal. HealthWell is trying to do its little part by really promising a couple of different things. One is to make sure that we meet the criteria of focusing a lot of our efforts in the oncology space. We promised in 2024 to make sure that we program out at least $300 million in out-of-pocket patient relief for medication copays for any of our oncology funds. Secondly, we promised to make sure that we would fund, either through ourselves or through some of our friends, an effort to focus on how to get better participation from a socioeconomic level in clinical trials in the oncology space. This benefits everybody. Of course, it benefits the patient to be able to afford to participate in clinical trials, but what if the pool of patients for all oncology clinical trials increased to include all patients, not just the patients that can afford to participate? Drugs will get to market faster, people will have more options faster. Total win-win. So we're trying to make sure that a rising tide lifts all boats in that space as well. Thirdly, we're going to focus on the caregivers in the oncology space. Those are the folks that are looking after, at great cost sometimes, folks in their household who have been unfortunately diagnosed with oncology. We're going to start in 2024 a caregivers relief fund to pay for some of the out-of-pockets. So if somebody has to stay home from work to care for a relative in their household, let's not make them pay a financial penalty for doing a good service to that patient as well. Thank you. You can see the other stuff that we're focused on here at HealthWell on the slides. But I can tell you that we are fully invested in conferences like this with stakeholders such as you guys, because to be honest with you, we come up with some pretty good ideas, but listening to this audience every year, I go home with a billion different new ideas on how we can help patients. So you can see that we're trying to do the right thing. Everybody on this stage is trying to do the right thing. Everybody in this audience is trying to do the right thing. So best practice sharing is the most important thing that I do every single year, and this is why this is my favorite conference on planet Earth. So I'm not trying to say that because I love the organizers, which I do, but it's because I love the audience and the participants because of your passion. So I'm hopeful that at the end of this, that you guys stand up and tell me what I can do better, because that's how I'm going to do better, by listening to you guys. And this is, you can see on this slide, basically a list of the different oncology funds that we assist with, but that's nowhere near where we can impact a patient. There are so many different cancers. We'd be happy to help patients in all of them as well. Can I pass that on to you?
We can't see the
Sorry, I can't
slides.
see the slide.
We're flying blind.
Just use your presentation. Just use your presentation.
Oh, it says health.
We
That's
already
why I
talked about
stopped.
this.
Okay.
So you need to see the slides.
Go ahead.
She wants her next slide.
Just put the slide up. It's not there, right?
It's right there.
That's HealthWell still.
How impressive are
Yep.
we?
Sorry.
Go ahead.
Okay.
Sorry about that.
No worries at all. Hi, again, I'm Kim Zabarak. I'm with Cancer Care. I started my career off as a civil litigator, but I did, through personal reasons, find that my skill set could be much better used to help people with challenges with diseases and conditions. Both my daughter and my mother, they were both in clinical trials at the same time for different conditions. So I transitioned from that world of large law firms to where many of you work with patients and real people every day. And it's been an honor to do that every single day for the last 20 some odd years. So Cancer Care provides a real variety of services, and like the prior panel spoke about, that patient journey. We try to touch on all different aspects within that patient journey to help patients get the care that they need and to also support their caregivers, which are an integral part of making sure that patients can get the best care and thrive as well. So we have a financial and copay assistance foundation. We also provide financial assistance to help meet practical needs. In fiscal year 2023, we provided over $81 million in financial assistance, both through our copay and our other financial assistance. And Carla addressed many of the practical needs, as did Alan: transportation to and from, the ability to put food on the table. Of course, the copays, many of which are out of the reach for patients to be able to afford. And as Alan said, there's no reason in the United States for people not be able to access their cancer treatments. So the three of us here are with different organizations. Many of you are with your organizations. And the key is that we do all work together. If for some reason we do not have a fund, we will help patients find a fund from another organization. And that collaborative spirit is critical to all the success, so we can meet the needs of all of our patients. Navigation is another aspect, which I know you're all very familiar with, and thank goodness it's getting more attention. It's getting more attention with Medicare and different codes. It is a starting point, but navigation is key for patients feeling that they're not adrift and lost in a black box with nobody listening, phone call after phone call, etc. So Cancer Care, the heart of our organization, is our approximately 45 oncology social workers, and they really work with our patients for navigation, but also for our individual counseling and our group counseling. And having an oncology social worker build that relationship with somebody and be able to get them through these challenging times, as well as to work with these caregivers, there's nothing like it, and without it, all I could say is I can relate back to my mother, who did not take advantages of services like this, and it was challenging to say the least. So we all understand that. We will also be presenting at the ASCO Quality Care. We've done some research on the benefits of our financial services and how they are helping patients with their financial toxicity, because patients who experience financial toxicity, they have worse health care outcomes, their quality of life is not as good, and other aspects of that. So we actually have a study that we'll be sharing at ASCO to show how our financial assistance, as well as that of Alan's and Carla's organizations and all of your organizations, make a key difference for patients and in their outcomes, in addition to their overall well-being. Again, I mentioned we have individual and support group counseling as well at Cancer Care. And we also have Cancer Care education workshops, as well as materials that you can actually, for those who like hard copy materials, as well as online. But the workshops, again, are run by oncology social workers or leading on oncology experts. So that is a major foundational support of Cancer Care, but like many of you here, the advocacy part goes hand in hand with that services part of helping people with cancer and other serious conditions. So I lead our policy work. Cancer Care is located in New York, I'm in DC, so it allows me to collaborate with other organizations such as all of yours, and that collaboration is key. We have, as Alan, I think Carla both mentioned, clinical trials. We have a program called My Trialist. Yes, you can get information about clinical trials on the FDA website, but it's confusing as heck, and it's daunting. And it's daunting for those of us who work within this space. So you can imagine being somebody who does not understand it. So My Trialist is there to help inform patients, what is a clinical trial? Is it right for you? Maybe it's not right for you, but let them know what it is. And there's also then to help them find a trial within a distance, because again, we all know that traveling is a hurdle both physically, emotionally, and financially. So the My Trialist site on our website and our program, you can put in a mileage. You're willing or able to travel maybe 50 miles for a clinical trial, maybe 100 miles, but you can personalize that and find what trials may be available for you. And then leading the advocacy and policy space, we also put out information and drafted toolkits to help other stakeholders understand, and those being employers. Employers play such a key role in making sure that cancer patients can get the treatment they need in a timely manner. So we have toolkits that go through the terminology for employers on prior auth, step therapy, copay accumulators, all those things, because the employer's choosing the health care for their employees, they're very busy. They don't understand the terminology. And of course, you have people coming in who try to, say, well, this is a good program and this is not. But only the employer knows their employees and the challenges that they may be confronting, the size of the company. So the employer toolkit is to really educate employers on that and what the important things. It may sound good, it may sound less expensive, but if your employees can't get the care that they need in a timely manner, that is not the plan that you want to go with, nor for those looking really at financial nor is it the least expensive in the end for a company either. We also have a toolkit on biomarker testing, which is so important in the cancer space. Again, this is to help inform employers about biomarker testing and the importance of including that and making sure it's comprehensive within the plans that they offer. Finally, I'm also leading a task force, a national task force of about 25 different organizations across disease states to help improve access issues. The task force I'm addressing is on alternative funding programs, and it really has become a major barrier for employees with self-funded plans to get access to the care that they need. So we're working across disease states and across organizations to try to educate and raise awareness, but also to stop practices that impair patients' ability to get the care that they need. Thank you.
Sure.
This is just resource slides for cancer care. They
no
will be
problem.
shared. I've been told they'll be shared after the conference with people in about
That's
30
right.
days.
If anybody wants to take a picture, now's the time. Okay. And more. And then you have.
So I
your own
think we're at this we've switched to solution mode. I mean, I'm listening to you talk, and again, I've had cancer twice, and from what I see every day, it's a lonely, really lonely place to be. There's a lot of fear, not only fear for your life, but fear for your family, and then a fear of talking about it. And there's a lot of shame. We hear a lot of parents who have a child with cancer, or they themselves have cancer, say, I can't talk about this because if I say I can't feed my children, or I'm afraid I'm going to lose my home, I'm afraid I won't be told about a clinical trial, or I'm afraid they'll skip some sort of test or scan, or worse, I'm afraid they will take my children from my home, because if you cannot afford the basics for your children, they can be removed from the home. I met an oncologist not long ago, a pediatric oncologist, who was treating an infant with leukemia, great prognosis with leukemia, and he talked about the fact that this baby was not getting better. He did a house visit and found this young mom of 3 children was feeding all 3 of her children the prescription formula meant for her infant with leukemia. And she broke down and said, it's the only food I have. How in this country does this happen when there are food resources in her zip code that could have been giving her food? So afraid to talk about it. So Family Reach created a financial resource center. It is online. You can access it 24/7. It's on familyreach.org. You can go to this website. You can download the tip sheets. You can start to learn how to talk about it, talk to patients about it, normalize the conversation. You can type in a zip code, and you can see what resources are available in your area. You can say, I need food, I need housing, I need utilities, and you can see what resources are available. They're all open. They have all been vetted within the last 5 days. It saves a lot of time, a lot of rabbit holes, a lot of stress. And we can see on the back end, we can see who is coming to this website, what resources they're looking for, where they're coming from, and this is directing my strategy on who do I need to partner with in these areas? Who do I need to say, look, your cancer patients need transportation here. Your cancer patients need food here. We can help. So it's driving my strategy to scale and have greater impact by these targeted interventions. You can also see which emergency financial assistance funds we have open for housing, food, transportation, utilities. The Financial Resource Center, we put it on our site in April. We have not announced it. It is bare bones, but it's there. And there are, on the back end, there are over 72,000 patients on this website looking for a basic need, and we haven't told anybody about it yet. So we are really hopeful that this site will get people talking about what is available and comfortable with the conversation. We also know that having a resource online is not enough and that a lot of patients drop off. So we piloted a pop-up that says, do you need to talk to somebody? We had 40 slots. They were filled in a day and a half. So now what we're working on is creating more bodies in a call center so that knowing the resources are there, knowing patients are coming to it, knowing they need to talk to somebody. So that is phase 2 of the Financial Resource Center. But in the meantime, visit it, use it, tell us what's missing. It's there for you to help your patients.
Thank you very much. And Kim, I know you have oncology social workers answering the phones at Cancer Care as well.
Yes, we have approximately 45 oncology social workers that really build a relationship and to meet the needs of the individual patient calling, as well as the caregivers. I want to make sure that caregivers are part of this conversation because they are integral to the health and well-being of the patients as well. So I don't know if we can talk a little bit about some gaps right now. But one of the gaps is the lack of a social worker national licensure compact. That's one challenge that I know some states have indeed entered into a compact with other states, but it's not national yet. So if we really want to, and this is such a doable challenge that we can overcome, we can get a national compact for social workers. For instance, we may have somebody who, our oncology social worker, say, is licensed in New York and the patient is originally in New York. Perhaps they go to Florida for a month. Maybe they have time and their doctor says they can go and get a little time away. Or maybe they need to go and stay with a relative in another state that they need care for. They're tired and this relative is offered or a friend offered to help them. Once that patient crosses the line and is no longer in New York where the social worker is licensed, our social worker, even though they've built a relationship, is not able to continue that discussion and that care while the patient is in another state. So this is something that I really think if we all come together, again, really push this issue, it's so important and it's so doable, but that's just one example of the gaps that can be addressed.
Yeah, thank you. So I can tell you that, first of all, the administration at the highest level is listening and soliciting feedback. Just after being part of the Moonshot resource page in September for HealthWell, they even asked myself and a member of Carla's staff to attend a minority health forum in April because they wanted feedback from the space as to what they can do to help folks who are on the DEI spectrum get the same access to level of care that they should be getting. And so they solicited opinions from about 80 different organizations there. It was headed by Xavier Becerra, who is the Secretary of Health and Human Services, and also had a little bit of a walk by Vice President Harris at the time. So they are listening. And what we're doing here, what I'm doing here, is also asking everybody here who you all are deputized, whether you know it or not, as experts in this space. What are we missing? What can organizations like ours do, or what can any organization do to help fill in some of these gaps? And with the last 10 minutes, I would love to hear from the audience, and maybe we can address that as a panel, where you see the gaps are or what questions you might have on the Moonshot in general that we can answer. But I can't see because of the lights, so somebody's just going to have to, yeah, just stand. I know this audience really well. Just stand up and yell it out.
But I got to tell you that these same challenges often affect people
No, that's very helpful and very true. So I don't know if you guys want to address that comment.
I'll just add, and you already all know that with insurance, some people with.
Yeah. Sorry about that. So the question was basically, yes, it's very important that folks who are a little bit lower on the socioeconomic ladder don't have equal access to care, but even people who aren't in that case can't afford the oncology medications that are out there. The example used was that a family that's not so bad off cannot afford a $425,000 a year astrocytoma drug, and that's going to be financially devastating even if they can do it. So let's not leave those discussions behind. So that we're going to just comment on that now.
So I was just saying that we all know that people with insurance, people with great insurance, cannot get access to care. We have some in this country, we have some of the most innovative, effective treatments anywhere in the world. And we, quote, have access to them quicker than people in most any other country. But that word access, what does that mean if, again, in your question, people can't actually get the drug? That is one of the things, just to bring it home to yours, this Task Force on Alternative Funding Program. I won't get into the weeds, but for those who don't know about it, it's vendors, for-profit vendors that go to self-funded plans to these employers and say, don't worry, I'm going to save you a lot of money and your patients will be fine, but we're going to exclude all specialty drugs, or we're going to automatically deny prior authorization for all specialty drugs. And then we're going to have the patients apply for patient assistance programs and get the drugs for free so your company doesn't have to pay for it. So patients learn of this from a letter or a call, and quite frankly, people who are fortunate enough to have insurance, whether it be through a fully funded plan, a self-funded plan, Medicare, Medicaid, they're not expecting this at all. And for those paying very high premiums, they're not paying it so that they can get their child's amoxicillin. While it's wonderful to have insurance for that, people are literally struggling to get food on the table, to pay insurance bills, healthcare insurance if they're lucky to have it, so that it does cover a cancer diagnosis, a hemophilia diagnosis, a cystic fibrosis diagnosis. So by these schemes, and they are schemes, to take advantage of patient assistance programs which are intended for those who have no other access. So first and foremost, these schemes drain PAP programs for those that have no other way. And it also leaves employees who have been dutifully struggling to pay without the means of getting life-saving care. So that is just one example of how the system is broken. And to be truly patient-centered, we say that word, we want to be that, but our system definitely currently is nowhere near patient-centered.
Carla, do you want to?
No, I mean, we're focused on non-medical needs, so I can't be helpful there. The only thing I can say, and not at that level, but when we have patients that are saying, this drug costs me this and I can't afford it, I say, allow me to help with your non-medical expenses so that maybe you can afford it, but not at that number.
Yeah, agree. And certainly HealthWell, we cover patients up to 500% of the federal poverty level in that household. So, but to your point, even if they're above that $425,000 is going to be ridiculously unaffordable for 99.9% of the households out there. So thank you for bringing that up and making sure that we don't forget those folks at all. Thank you. Yep. Yep.
There's a problem with the middle class that they are not able to access. Hold on 1 second. I'm bringing you a mic.
I can't see you, but I think that's Molly.
Yeah, it is me. Hi, Carla. When I was diagnosed with cancer in 2005, I had a COBRA premium of $1,300 a month for myself and my 5 children. And because my previous year's income put me in the middle class, I was knocked out of any food support, rent support, transportation support. my kids, we ended up in line at a food bank. And one of my concerns about a lot of these programs is that the middle class doesn't have access to our social safety nets. So that's one. I also want to ask about family medical leave. If that it would be paid. I want to know where you see that in our country. That affects both caregivers and patients.
That would be policy, is that?
Yeah, that's policy.
Yeah, I mean, we're not there. We're not there yet as a nation. Some states are ahead of other states on that, but clearly that's another thing that says, are we truly patient or person-centered in this country? And we're not. We're not there. So, and you're right, for both caregivers, there is movement on the caregiver side to recognize the financial value. Of course, there's the emotional and value and the work that caregivers do. But there has been some work on the policy end to try to bring forth potential answers for caregivers and how we can assist them. Because if a caregiver works part-time or has to totally leave the workforce, which happens quite frequently, they too have no income. They too will not have their Social Security benefits and all of that. It is a snowball effect, and the only thing is that we can't let those issues, oh yes, paid family leave, we all know it and it goes to the wayside. We have to stay active on it, and we have to keep all of these very, very fundamental issues front and center.
So my overall concern on paid family leave is that the costs will be passed on to the consumer in terms of just their basic needs, food, transportation, cost of consumer goods, because I think it's unaffordable. And it will not help smaller companies under 50 employees and the people that are often really at risk.
You're so spot on. Even just the right now, the cutting or capping drug costs, what is the result of that? Pharma companies are cutting back on their advocacy dollars. It's like you try to do one thing and then it backfires on the other. Pharma used to give us millions. Those budgets have been totally slashed, and they're saying it's because capping the drug cost. And that's why in the beginning, and I said that the moonshot, the goal is to increase cancer survival rates by 50%. We know what to do. We know who needs to do it. I know it's not that simple, but these 2 points that you just brought up, yes, let's fix that. That alone would have a dramatic impact on cancer survival rates.
Thanks. And one last question while we have zero time is, last time I was here, I think the audience in general thought that there was a huge gap in affording radiation oncology for patients. Is that still the case, or has that gotten better? Okay, so that's still something that needs work. So I can tell you, the folks on the stage are certainly mindful of that. Easier said than done to get funding there, because it's basically who's going to provide that. Certainly the hospitals can do it, the machine manufacturers can do it, but it's not as cut and dry as medication copay, which is certainly helped out by as Carla alluded to, the pharmaceutical industry in general. So if there's anything else, I know we're running a little bit over, that we should be mindful of, please let us add to the list. Otherwise, thank you very much for your participation. Look forward to the continuation of the most outstanding conference of the year. Thank you so much.